In this session of the PEM Fellow Research Design course, we will discuss how to design
observational studies. This is the fourth topic in the research design course. The goals of this talk are to distinguish between random error, that is statistical in nature, and systematic error due to biases in study design. To review the differences between statistical association and causation, and review the types of observational studies and discuss their benefits and limitations. When we design a study, we start with a research question. We decide on the population that we are interested in to answer that research question and enroll a sample of that population. We then collect and analyze data, draw conclusions from the data, and extrapolate those conclusions back to the population of interest. This process is called statistical inference. There are two types of error that we encounter in statistical inference: random error and systematic error. Random error is due to chance and is presented as a probability. It is derived from statistical analysis and expressed as a p-value or a confidence interval. The correction for random error is increasing power by having an adequate sample size and making accurate measurements. In contrast, systematic error is based on biases or lack of validity in the study design. Systematic error is directional, that is, it will bias the study results in one direction or the other. The correction for systematic error is good study design. Good study design minimizes bias, maximizes validity, and limits systematic error. Some systematic errors are inherent to the type of study, and some can be controlled by the investigator. The term external validity means that you can generalize from the study's group to the general population. We often refer to this as applicability. The term internal validity means that the study measures what it intended to. Bias undermines the internal validity of a study. There are over 30 different types of bias. There are often many names for the same concept and can get confusing quickly. Types of bias can be categorized into one of three categories. These are selection bias, information bias, and confounding bias. Selection bias is the absence of comparable groups. Ask, are the groups similar in all important respects? Information bias is the incorrect determination of exposure, outcome, or both. This is also known as observation bias, classification bias, measurement bias, or ascertainment bias. Ask, has information been gathered in the same way, and is the information bias random or in one direction? In retrospective studies, recall or record bias is a type of information bias. In prospective studies, detection bias is a type of information bias. We will get back to these biases a little bit later in this talk. Confounding bias is the mixing or blurring of effects. Ask is an extraneous factor blurring the effects. Bias is inherent to all observational study designs. The ability to control bias is the benefit of randomized clinical trials and the reason they are considered to be a higher level of evidence. We have discussed how to format a research question with PICO and how to determine if a research question is answerable with the finer criteria. We will take a brief detour around defining a study population and variables and focus on determining which study design will best answer your research question. Studies can be described by their attributes. Typically, observational studies conclude whether an association exists, while interventional studies define a causal relationship. Observational studies provide a measure of association between an exposure intervention and no exposure or no intervention. A statistical association does not imply a causal relationship. For example, carrying a lighter is associated with lung cancer, but is not the cause of lung cancer. The Bradford Hill causation criteria describe factors that increase the likelihood that an association is causal in nature. Is there temporality? Does the cause precede the effect? Is the result plausible? Are the results consistent with existing knowledge? Does the science make sense? Have the results been consistent? Have the same results been found in multiple studies? How large is the strength or magnitude of the effect? A larger magnitude of effect is more likely to be causal. For example, a risk difference of 10% is more likely to be causal than a risk difference of 1%. Is there a dose-response relationship? Does a larger exposure result in a larger effect? Is the effect reversible? Does a smaller exposure result in a smaller effect? Is the study design robust? Have steps been taken to limit systematic error and biases? And do multiple lines of evidence lead to the same conclusion? Another attribute of studies are their orientation in time. Prospective studies are looking forward in time, and retrospective studies look backward in time. Studies can be descriptive or comparative. Descriptive studies analyze one study group or intervention. Comparative studies analyze more than one study group or intervention. Studies can also be described as observational or interventional. In observational studies, events are not under investigators' control. In interventional studies, investigators can control events and utilize methods to limit systematic error or bias. This is why interventional studies are considered a higher level of evidence, and their conclusions are more likely to represent a causal relationship. There are several study designs available when designing a study. Descriptive studies are typically case reports or case series. Observational studies are typically cohort studies, case control studies, or cross-sectional studies. Interventional studies are commonly called clinical trials. These include randomized clinical trials, crossover studies, and quasi-experimental studies. The focus of this session is on observational studies. What type of question are you asking? Is it a treatment, harm, diagnosis, or prognosis question? What is the best study design to answer that type of question? Observational studies are traditionally best to answer questions about harm and prognosis. However, observational studies are increasingly been used to answer treatment questions. Observational studies are described as experiments of nature. Allocation of patients to a study group is not under investigator control. They are simpler to conduct than interventional studies and are sometimes the only study design available if an interventional study would be unethical or not feasible. For example, it would be unethical to randomize children to radiation exposure or no radiation exposure to determine the future risk of cancer in an interventional study. It would not be feasible to enroll 10,000 pediatric patients in a sedation study. It is much easier to use an existing sedation database. Observational studies are considered weaker empirical evidence due to their potential for greater confounding bias. Observational studies may serve as a preliminary evidence to support a randomized clinical trial. We will start with cohort studies. The word cohort simply refers to a group of subjects. Historically, cohort studies are used for prognosis and harm questions. More recently, they've been used for therapy studies, particularly with large database studies. Cohort studies can be both descriptive and analytic. They can describe the prevalence or incidence of an outcome. They can also analyze the association of an exposure or intervention and an outcome. The steps in a cohort study are to define the population sample, measure exposures, and measure outcomes. In a prospective cohort study, the exposure occurs in the present and the outcome occurs in the future. In a retrospective cohort study, the outcome occurs in the present and the exposure occurs in the past. This slide illustrates a cohort study's orientation in time. In a prospective cohort study, an exposure is measured in the present, and patients are followed into the future when an outcome is measured. This is typical design for prognosis studies, in which the exposure is a prognostic factor of a disease and the outcome is a disease consequence, such as mortality. In a retrospective cohort study, an outcome is measured in the present, and an assessment is made to determine if the exposure occurred in the past. Let's look at an example of a prospective cohort study. A cohort of pediatric asthma patients receiving chronic inhaled corticosteroids and a cohort of asthma patients not receiving chronic steroids are followed over time to determine the effect of chronic inhaled steroids on growth. Now let's look at an example of a retrospective cohort study. A cohort of patients with epilepsy is identified in the present, and records are reviewed to determine if there is an association of prior febrile seizures with developing epilepsy. The nature of retrospective data has changed considerably in recent years. In the past, retrospective data meant reviewing the patient chart or asking the patients about their past. Currently, there are many other sources of retrospective data. You can review the electronic health record or administrative databases. These may not always have the data that is needed to answer the research question. In contrast, research databases systematically collect the appropriate data. Examples of research databases are trauma and airway registries. The strength of a cohort study include they limit risk to human subjects when an interventional study is not feasible or ethical. They can establish a temporal relationship with an increase in the likelihood that the association is also a causal relationship. They can measure the incidence or prevalence and calculate a relative risk rather than an odds ratio. Cohort study weaknesses include they are inefficient for very rare outcomes when a large sample size will be required. Prospective cohorts may require a long follow-up period that will increase study duration and expense. It may be difficult to obtain controls if an exposure is common. For example, it would be difficult to find a cohort of children who have never watched TV to determine the association of TV watching and violent behavior. There are also several potential biases. For prospective cohort studies, a proportion of the patients may be lost to follow-up, and detection bias may occur. Detection bias is when those with an exposure are followed more closely than those without the exposure, and therefore the outcome is more likely to be detected. For example, a patient with an occupational exposure to high levels of radiation may be followed more closely and intensely for the development of cancer, and therefore make it more likely that cancer will be detected in the exposed group. Detection bias is a weakness of prospective cohort studies. Recall bias may affect the measurement of the exposure in a retrospective cohort. Patients may fail to recall an event if they don't have the outcome, or be more likely to recall the event if they have the outcome. For example, the parents of a child that develops leukemia may be more likely to remember that their town had a chemical factory than those with a child without leukemia. Record bias may also affect the measurement of the exposure in a retrospective cohort. Record bias occurs when the information about the exposure may not have been adequately documented. Recall bias and record bias are weaknesses of retrospective cohort studies. Propensity scoring is increasingly being used in cohort studies. It serves the same purpose as randomization does in randomized clinical trials. Propensity scoring can overcome the selection bias and confounding bias inherent to observational studies. The intent is to have groups that are comparable in confounding variables so that you can assess the association of the factor of interest on the outcome. Propensity scoring matches patients with other patients who have the same known confounding variables. Unlike randomization, it does not match for unknown confounders. Unfortunately, the more variables that are matched, the least likely it is to find a match. One of the downsides of propensity scoring is that the analysis only includes those for which there are matches. This results in a decrease in sample size and a loss of power. In addition, if unmatched patients have a factor that is not present in the matched patients, then the analysis cannot assess the association of that factor with the outcome. This table compares prospective cohort studies to retrospective cohort studies. In a prospective cohort study, the exposure occurs in the present, and in a retrospective study, the exposure occurs in the past. In a prospective cohort study, the outcome occurs in the future, and in a retrospective study, the outcome occurs in the present. Prospective cohorts are typically more expensive due to the need to follow patients over time. They also take longer to conduct. Prospective studies are at risk of detection bias. Retrospective studies are at risk of recall and recording bias. Subjects selected for a cohort study should be appropriate to the research question and a representative sample of the population. For prospective cohort studies, it may be necessary to exclude those likely to be lost to follow-up and to collect long-term contact data. Sample size determination should take into account the proportion of patients who will be lost to follow-up. In cohort studies, ensure that measurements are both precise and accurate. Exposure should be measured at baseline and repeated, as new exposure may occur. Potential confounding variables should be measured at baseline. Exposures and outcomes should be assessed blindly and use standardized criteria. These are the user's guide to the medical literature risk of bias questions for a cohort study. They should be considered when designing a cohort study. Did the exposed and control groups start and finish with the same risk of the outcome? Were the patients similar for prognostic factors that are known to be associated with the outcome? or did the statistical adjustment level the playing field? Were the circumstances and methods for determining the outcome similar? And was follow-up sufficiently complete? Next, we'll review case control studies. Case control studies include a group with the outcome, the cases, and a group without the outcome, the controls. They are retrospective and the best observational study design for rare outcomes. Disease prevalence cannot be calculated. Disease prevalence is determined by the ratio of cases to controls that is selected by the investigator and not by the natural occurrence of disease. Case control studies cannot calculate a relative risk or risk ratio. Only an odds ratio can be calculated as a measure of the magnitude of the association between the exposure and the outcome. In a case control study, a cohort of patients with the outcome of interest, the cases, and a group of patients with the outcome, the controls, are identified. These groups are then retrospectively assessed for the exposure in the past. In this study, groups of patients with and without intussusception were identified. They were then retrospectively assessed to determine if they had been exposed to a new rotavirus vaccine. The study established an association between the first rotavirus vaccine and the risk of intussusception. The strengths of case control studies include that they limit risk to human subjects when an interventional study is not feasible or ethical, and they may be the only feasible method to evaluate rare outcomes. Potential weaknesses of case control trials include limitations in the measure of association obtained and potential biases. Because the investigator determines the number of patients in both the case and control groups, a true prevalence or incidence cannot be calculated. An odds ratio does not depend on prevalence and is used as a measure of association. Potential biases include confounding bias when there is an unequal distribution of potential confounders in the cases and control. Case control studies are retrospective and are subject to the same weaknesses as retrospective cohort studies. Recall bias occurs when there is an inadequate or biased memory of the exposure. Record bias occurs when the information about the exposure may not have been adequately documented. Survivor bias occurs when patients who have already died may not be included in the case group. It is important to avoid information bias in case control studies. Cases should be a random sample considering undiagnosed cases and misdiagnosed cases. For controls, consider matching for confounders using propensity scoring and using 2 or more control groups. Measurements should be precise and accurate. If possible, use data recorded before the outcome occurred. Investigators should be blinded to the predictors and the outcomes. These are the user's guide to the medical literature risk of bias questions for a case control study. They should be considered when designing a case control study. The cases and control groups have the same risk of being exposed in the past. Were cases and controls similar with respect to the indications or circumstances that would lead to exposure, or did statistical adjustments address the imbalance? Were the circumstances and methods for determining exposure similar for cases and controls? We will finish our discussion of observational studies with cross-sectional studies. A cross-sectional study is a design in which you collect data at a single point in time. In this example, emergency medicine residents were surveyed to assess their prior experience with pediatric cardiopulmonary arrest and their level of comfort with pediatric cardiopulmonary arrest to determine if there is an association between prior experience and level of comfort. Like other observational studies, cross-sectional studies limit the risk to human subjects and may be the only design feasible when an interventional study is not ethical or feasible. Since assessments occur in a single time frame, cross-sectional studies are of short duration, inexpensive, and do not require follow-up. In large database studies, more than one outcome can be studied. Weaknesses of cross-sectional studies include that they are inefficient for rare outcomes. In addition, since assessments occur in a single time frame, cross-sectional studies do not establish temporality. Similarly, cross-sectional studies yield a prevalence but not an incidence as a measure of frequency. Because the outcome and exposure are measured simultaneously, this is a review of the orientation in time for observational studies. A randomized clinical trial is included for comparison. Cross-sectional studies take place at one point in time. A prospective cohort study begins in the present and follows patients into the future. Prospective cohort studies most closely follow the timeline of a randomized clinical trial. Both retrospective cohort and case control studies identify the outcomes in the present and look to the past to assess exposures. Choosing a study design is a matter of accepting trade-offs. Prospective cohort studies have the highest likelihood that the association represents a causal relationship but require more time and expense and are not good at rare outcomes. Retrospective cohort studies have a lower likelihood than the association represents a causal relationship than prospective cohort studies, but generally take less time and are less expensive. They are also not good for rare outcomes. Cross-sectional and case control studies have the lowest likelihood that the association represents a causal relationship, but take less time and are less expensive than cohort studies. Case control studies are the best design for rare outcomes. Guidelines for conducting all types of studies can be found at the Equator Network website. This is a great place to start once you have selected a study design. The STROBE, or Strengthening the Reporting of Observational Studies in Epidemiology, are highlighted above for observational studies. The analysis of observational studies results in a measure of frequency and a measure of association. There are two primary measures of risk frequency. Prevalence is the number with the outcome at a point in time divided by the number at risk for the outcome at a point in time. For example, the prevalence of serious bacterial infection in febrile infants is 10%. Incidence is a measure of risk which includes a time interval. Incidence is the number with the outcome over a specified time interval divided by the number at risk for the outcome over that time interval. For example, the incidence of death from acute lymphoblastic leukemia is 10% in the first year. There are measures of the magnitude of association that are paired with each of these measures of frequency of association. For example, relative risk measures a relative prevalence, while hazard ratios measures a relative incidence. To understand the concept of odds, it is helpful to compare it to risk. A risk is the number of times an event occurred divided by the number of times it could have occurred. For example, the risk of drawing the ace of spades from a deck of cards is 1 out of 52. And odds is the number of times an event occurred divided by the number of times it did not occur. Notice the difference in the denominator for risk and odds. The denominator for risk is the number of times an event could have occurred. The denominator for odds is the number of times an event did not occur. The odds of drawing the ace of spades from a deck of cards is 1 out of 51. Risk and odds are very similar when the event is rare, such as drawing the ace of spades from a deck of cards. As we move down the table, the likelihood of the event increases. As the likelihood of the event increases, the difference between risk and odds also increases. For interventional treatment studies, a risk is most commonly used. For observational studies, a risk is used for cohort studies and odds for case control studies. For an interventional study, the relative risk is defined as the risk of the outcome in the intervention group divided by the risk of the outcome in the control group. For an observational study, the relative risk is the risk of the outcome in the exposed group divided by the risk of the outcome in the non-exposed group. The syntax is the same for an odds ratio. For an interventional study, an odds ratio is the odds of the outcome in the intervention group divided by the odds of the outcome in the control group. For an observational study, an odds ratio is the odds of the outcome in the exposed group divided by the odds of the outcome in the non-exposed group. Let's take a look at a 2x2 table of a typical cohort study. The risk of the outcome in the exposed group is 50 divided by 200. That is 0.25 or 25%. The risk of the outcome in the not exposed group is 100 divided by 200. That is 0.50 or 50%. The relative risk is the risk in the exposed group divided by the risk in the non-exposed group. It is 0.25 divided by 0.5, which equals 0.5, or 25% divided by 50%, which equals 50%. Let's now determine the odds ratio from the same table. The odds of the outcome in the exposed group is 50 divided by 150. That is 0.33 or 33%. The odds of the outcome in the not exposed group is 100 divided by 100. That is 1 or 100%. The odds ratio is the odds in the exposed group divided by the odds in the not exposed group. it is 0.33 divided by 1, or 0.33, or 33%. If this was a case control study, the ratio of cases to controls is set by the investigator. Therefore, the prevalence of disease is not a natural occurrence. Only an odds ratio could be calculated. How do we interpret relative risk and odds ratios from observational studies? A relative risk greater than 1 indicates that the risk in the exposed group is greater than the risk in the not exposed group. A relative risk equal to 1 indicates that the risk in the exposed group is the same as the risk in the not exposed group. In other words, there is no difference between the groups. This is an important concept. A confidence interval for a relative risk that includes 1 indicates that there is not a statistically significant difference between the exposed and not exposed group. A relative risk less than 1 indicates that the risk in the exposed group is lower than the risk in the non-exposed group. Odds ratios are interpreted in the same fashion. The outcome measures available differ for the types of observational studies that we've discussed in this talk. Prospective cohort studies yield an incidence as a measure of disease frequency and a relative risk as a measure of the strength of association. Retrospective cohort studies yield a prevalence as a measure of disease frequency and a relative risk as a measure of the strength of association. Case control studies do not yield a measure of disease frequency because the investigators select the ratio of the cases to control, and therefore only an odds ratio can be calculated as a measure of the strength of association. In summary, observational studies are less expensive and easier to conduct when compared to interventional studies. In addition, they limit the risk of human subject research that can occur with interventional studies. They are good for research questions focusing on harm and prognosis, but they are increasingly being used to study therapy questions as well. However, they have a greater potential for bias than interventional studies and represent a weaker level of evidence. Observational studies provide a measure of association, but do not necessarily represent a causal relationship. On to our questions. Which observational study design is not subject to recall bias? Case control study, randomized controlled trial, retrospective cohort study, or prospective cohort study? The answer is D, prospective cohort study. Recall bias can occur with retrospective study designs. The outcome is measured in the present and the exposure is assessed based on the past. Memory may be faulty or biased by the presence of the outcome. Both retrospective cohort studies and case control studies are retrospective. The only prospective observational study is a prospective cohort. A randomized clinical trial is an interventional study and not an observational study, and randomized clinical trials are prospective. Which observational study design is subject to detection bias? Case control study, randomized controlled trial, retrospective cohort study, or prospective cohort study? The answer is D, prospective cohort study. Detection bias occurs when the exposed group is followed forward in time and may undergo more rigorous evaluation for the outcome. For example, patients with an exposure to a known carcinogen may be followed more closely and undergo screening tests for cancer more frequently. Therefore, the outcome is identified more frequently in the exposed group. This may artificially increase the measure of association between the exposure and the control. The only observational study design that follows patients forward in time and is therefore susceptible to detection bias is a prospective cohort study. Which observational study design cannot be used to obtain a disease prevalence or incidence? Case control study, randomized controlled trial, retrospective cohort study, or prospective cohort study? The answer is A, case control study. The investigators determine the ratio of the cases to controls in a case control study. For example, the investigators may choose 50 cases and 50 matched controls. The prevalence of cases is set at 50% by the investigator. A prevalence or incidence cannot be calculated from a case control study. A prevalence or incidence can be calculated from a retrospective or prospective control study. A randomized clinical trial is not an observational study design. A study presents a risk of illness as 15 deaths per person per 2-year period. This measure is called prevalence or incidence. This is an incidence. Incidence is defined as the rate of an outcome over a specified time interval. For example, many cancer studies report a 5-year survival rate. Prevalence is defined as the rate of an outcome at a specific point in time. What would not increase the likelihood that a statistically significant association is also a causal relationship? Biologic plausibility, a temporal relationship with exposure preceding an outcome, a large magnitude of association, a large sample size, reproducibility of the study's results, or dose-response relationship. The answer is a large sample size. Observational studies provide a measure of association, but a statistical association does not necessarily imply a causal relationship. For example, carrying matches or a lighter is associated with lung cancer, but matches and lighters are not the cause of lung cancer. There are a number of factors that increase the likelihood that an association is a causal relationship. This is defined by the Bradford Hill criteria. Biologic plausibility means that the science makes sense. The strength of magnitude of association can also increase the likelihood of causality. For example, a relative risk of 10 is more likely to be causal than a relative risk of 2. A dose-response relationship is seen when a higher magnitude of effect is seen with a higher degree of exposure, such as a higher dose of medication. A temporal sequence is present when the exposure had to precede the outcome. And repeat studies that demonstrate the same direction and magnitude of the association can help to establish causality. A larger sample size can increase precision by narrowing the confidence interval, but it does not increase the likelihood that an association represents a causal relationship. The next topic in the research design course is the design of interventional studies.